Thank you for joining me in my video blog series, Moving Out of the Problem into the Solution. Today I want to talk about identifying all the obstacles that patients run into for positive outcomes. The premise here is, in order to solve a problem, you've got to know you have the problem first. So let's talk about three major areas that can sabotage effective outcomes. But first, a little bit about me. I'm coming at this both personally and professionally. I've been living with my own chronic pain for many, many moons since 1982. I've developed a system for treating chronic pain and coexisting disorders, calling it the Addiction-Free Pain Management Manualized Treatment System. And I've written several books. I'm in the process of ready to submit my new book for publication. And if you're watching this on YouTube or somewhere other than on my website, make sure you check out my website, drstevegrinstead.com, and especially the My Services page, where this is where these video blogs are parked, but also have 3 new articles posted. I rotate these and refresh the content on both video blogs and the articles every several weeks. So I always keep new content on my website. So what are some of the common obstacles that get in people's way when they decide, hey, this isn't working for me, I need to find a better way to manage my chronic pain? Well, I believe the number one and top offender is the patient and the healthcare provider's failure to either recognize, identify, or treat some of the coexisting disorders. What I'm talking about here is possibly mental health problems like depression, anxiety, trauma, post-traumatic stress disorder, and medication misuse, abuse, or even medication use disorder. So those are some of the things that often get looked at, but not really accurately seen. And if they are seen, they're sequentially treated instead of concurrently treated. That's a big obstacle for people for successful outcomes. Then there's the family system. If the family doesn't get help, the pain patient isn't going to get the type of support they need and deserve. There's a lot of different problems in families. One is the enabling behaviors, doing something for their loved ones that they mistakenly believe they can't and shouldn't be doing for themselves. And then at some point, though, there becomes burnout, that people get angry, upset, resentful. I've seen marriages fail because of one partner not being able to live with another one that has undertreated or mistreated chronic pain. Then there's the judgmental healthcare providers. And sometimes when we look at people, are we really seeing the person, or are we seeing them as a diagnosis? So a lot of times when patients come to me, they say, my doctor, my nurse, my case manager, my physician assistant, whoever it is, doesn't believe my pain's as bad as I know it is. And now the reason they're sending me to you is because they think it's all in my head. I'm making this up, or I'm somaticizing it. A lot of times there's a blame the victim or blame the patient mentality from a lot of providers, that they're not trying hard enough. If they just do differently, they would, buck up. Other people really respond to this treatment. Why aren't you? And maybe it's because you're drug seeking, you're med seeking. So when patients are confronted with these kind of insensitive and judgmental providers, it pushes them in places that aren't very pretty. So let's talk about the next area. The patient's self-defeating reactions. And number one offender is when people want to be fixed. They're looking for the magic pill, shot, procedure, surgery, the magic bullet. They become passive recipients of their own healing process instead of active participants and co-partners with their healthcare providers. They need to be proactive and active participants. There's a lot of times, though, these patients just get into what I call malicious compliance to keep the medications coming. It might be a people-pleasing, or it might be a out to fool you mentality, but whatever it is, it doesn't help anybody. That's one of the reasons the opioid epidemic has gotten so bad, is overutilization of opioids for chronic pain, when there's no level 1 research that proves it's effective for chronic pain. A lot of times people living with ongoing levels of high pain get into a hopeless and helpless mindset. I call it the chronic pain trance. They have despair and they get hopeless. They believe, what's the use? Some of them even get suicidal. There's a lot of grief and loss over prior levels of functioning and quality of life, and then tremendous shame and guilt for not being the person they should be, the parent, the partner, the student, the worker, whatever it is. And I know that when I got injured in 1982 and my construction world was taken away, my teaching martial arts world was taken away, I was in that pit, that chronic pain trance. And it was not a very pretty place to be, and the grieving process took a long time to work through. Many people develop internal and external depression and other coexisting problems. The common ones are trauma, unresolved trauma like post-traumatic stress disorder, cognitive distortions because of living with high levels of pain. Some people develop eating disorders, sleep disorders. There's a lot of different problems that people suffering with chronic pain experience, and a lot of times they don't get identified and or treated concurrently, and that can lead to serious problems with having a high quality of life and good outcomes. There's a lot of resistance and denial with people. They have a mistaken belief that there must be the right medication, the right procedure, pain procedure, the right surgery, the right practitioner, the right therapist, whatever it is. And they have a lot of resistance and denial to think outside the box. I want to invite and encourage my patients to get rid of the box. Look at this differently and have some hope. It's impossible to be in suffering and gratitude and hope at the same time. A lot of times the big obstacle is power struggles between pain patients and their providers. I've been in these with some of mine until I notice what's going on, and I say, whoa, wait a minute, we're supposed to be on the same team here. As I mentioned earlier, grief, loss, and depression are very common. So I always recommend that when we're looking at where people are at, that we start identifying where they're at with these grief, loss, and depression symptoms. So we need to assess for the grieving process. Where are they at? Because there's different stages. Total denial, distraction, depression, pleading and bargaining, finding the right approaches, semi-acceptance. There's a lot of different stages people go through. And the bottom line is the patients need to have hope. My very first session with someone, if I haven't given them a bit of hope, I probably won't see them again. So I am always trying to build hope, that there is always hope. While we breathe, there is hope. I want to move them from that victim stance that a lot of them put themselves or get themselves in, and lead them to a sense of empowerment. And it needs to move beyond surviving and into thriving. Depression is another condition that often doesn't get uncovered. A lot of people build great facades when they're depressed. To the outside world, they can appear to be doing just fine up until the point they attempt or complete suicide. So that's the end stage of untreated depression for many people. So some people are going to need medication management. Some people are going to only need cognitive behavioral therapy. And I've looked at the research over the years, and I've also practiced in my practice If I see somebody at the moderate stage, maybe even a little above moderate, I always want to start with what we call cognitive behavioral interventions. Have people start looking at their beliefs, perceptions, and thoughts that occur because of their depressed state. What kind of emotional reactions does this lead to? What kind of urges and impulses that aren't that healthy does that generate? And then what kind of decisions do people make to do self-defeating behaviors? And then this doesn't happen in a vacuum because it impacts their friends, family, and community. So I want to assess all this and see where this is going on and help people move out of the problem into the solution. If it's moderate to severe, the research is really clear. These people need a combination of cognitive behavioral interventions along with an appropriate medication management plan. I call it recovery-friendly medication management plan. And some of the medications we're talking about are also really awesome for helping patients with their pain symptoms, not just the depression. I'll talk about that in a future session. There's more problems that can also sabotage outcomes. One of the big things, especially when people go into treatment programs, is right near the end of treatment, they start working on relapse prevention. Well, I believe that relapse prevention and continuing care planning needs to start right at the beginning of treatment. And when I say relapse prevention, a lot of people think, well, this isn't an addiction problem, it's a pain problem. Yes, it is, and it might be a medication use disorder problem too, but even if it's not, we need to have a plan to help with pain flare-ups so people don't automatically just go and take extra oral medication when there's other non-pharmacological interventions that can work quicker and better. They also have a really big tendency to sabotage themselves with not having an adequate or proper activity pacing plan. And for some people that means they're too sedentary, they need to be pushed. But I know for me, when I was going through my rehabilitation, I had to be slowed down because I kept flaring myself up. So it's finding where you're at and doing an adequate and effective proactive activity pacing plan. Craving management plan. And this is true for people with medication use disorders, because there's going to come a time when they think nothing but the pain meds is going to fix them. So we need to give them other non-pharmacological tools. I often tell my patients that when you're having cravings, there's only two ways they'll go away. Number one, they'll go away if you use something, and number two, they'll go away if you don't use something. However, unfortunately, they'll stay forever if you entertain them. So having an adequate craving management plan is crucial. And developing appropriate accountability partners, I can't tell you how important that is. So having people that are non-judgmental but yet are going to hold the line with you and help you be successful with your goals. The other thing is unrealistic expectations. For a lot of my addiction colleagues, there's this zero tolerance, don't take nothing no matter what, because abstinence is the solution. And for people with chronic pain, they may need to be on appropriate recovery-friendly medication management. I'll talk more about that in a minute. For my mental health providers, they have a mistaken belief that the only thing the person needs is intense psychotherapy. And that's not enough. And then for pain management providers, the biomedical approach is the solution. And then for the poor family members, they say, please just help or just fix them. So the answer is there needs to be a combination of all of these. Appropriate medication management, dealing with the core psychological emotional components of the pain, and appropriate medication management that's recovery friendly and won't trigger a relapse. And the family members need to be getting help too. Another serious obstacle is medication-assisted treatment, or the lack of. There's serious lack of people being able to access recovery-friendly MAT for treating chronic pain with coexisting disorders. In fact, only about a third of the people that really need it are going to be able to get it. This needs to change, but it needs to change in a way that people are not just implementing medication as part of it, but also psychosocial modalities need to be involved. There's a lot of obstacles that with medication-assisted treatment, because there's many treatment providers and 12-step recovery programs that think people that are on medication-assisted treatment aren't really in recovery. This is not true. This is from the Substance Abuse Mental Health Service Advocacy tip number 63, and it talks about, we believe that patients taking medication for opioid use disorder, OUD, are considered to be in recovery. And that there are several barriers that continue to contribute to the underuse of medication or using only medication for opiate use disorders. So there's two sides. So I like to always end on a positive note, moving onward and upward with hope. So as you were going through this presentation, take a moment to jot down some of the most important highlights that struck out to you. And then take a look and try to have a list of 4 things that you can commit to do differently to identify the obstacles to improved levels of functioning in your own quality of life. If you're a professional watching this, this applies to you too. Because if we don't start taking care of ourselves and applying what we learned ourselves, how are we going to transpose that to the people we serve? What barriers might you encounter, and how can you get help to overcome any obstacles or problems? And finally, who are 3 appropriate accountability partners you can ask to be part of your team, to be part of the solution? So again, I really appreciate you joining me for this video blog, and I hope that something that we've talked about today will be helpful for your ongoing health and healing, or if you're helping people or friends or loved ones are suffering with chronic pain, please share this with them. And thank you a lot, and I'll see you at the next one.